There's no such thing as safer blood pressure medication. There's only the right medication in the right body, managed correctly for as long as it is taken, and stopped the right way when the time comes to stop it. I am going to tell you that directly now, before anything else. Because the question this video is built around, which is, safer is the wrong question, and answering it honestly requires telling you what the right question actually is. In 13 years of emergency medicine, I have never once had a patient arrive in my department because their doctor made a bad choice between these two drugs. I have had dozens arrive because nobody told them what that choice meant for their specific body, their specific situation, and the specific morning when something changed. The drug itself was rarely the problem. The conversation that was supposed to come with it was, "My name is Miles. What I want to give you today is that conversation. Because these two medications do not work through the same system. They do not fail in the same direction, and the safety question has a completely different answer depending on which body it is asked about." Before we go further, I want to be direct. Both amlodipine and metoprolol are well-studied, widely used, genuinely effective medications. I am not here to tell you one is better and one is worse in any universal sense. I am here to tell you that the wrong drug in the wrong body for the wrong reason is where the problems I see in my department tend to start, and the difference between those two scenarios lives in detail almost nobody explains at the point of prescription. If you would rather understand those details than discover them later in a hospital, subscribe right now. This channel was built for that conversation. Here is the mechanism, because nothing else I say today makes sense without it. Amlodipine is a calcium channel blocker. Picture the walls of your blood vessels as muscle tissue that has to be told to relax. That instruction depends on calcium flowing into the muscle cell. Amlodipine reduces how much calcium gets in, which loosens the muscle, widens the vessel, and drops the pressure. It works at the level of the vessel wall itself, regardless of what signals your heart is sending. Think of it as prying open a clenched fist from the outside, not by changing the signal from the brain, but by directly loosening the grip. Metoprolol is a beta blocker, and it works on an entirely different system. Your heart rate and the force of each beat are partly governed by adrenaline, which binds to receptors on the heart and tells it to work harder and faster. Think of adrenaline as a foot pressing an accelerator. Metoprolol stands between that foot and the pedal. It does not remove the foot. It limits how far the pedal can go down. The result is a slower heart rate, a less forceful beat, and lower blood pressure as a consequence of that reduced workload, not from any direct effect on the vessel walls. Two drugs, two completely different systems, and that difference is the entire reason the safety question does not have one answer. The first scenario, where the answer flips, asthma or chronic lung disease. Beta receptors, the same receptors metoprolol blocks on the heart, also exist in the airways of the lungs. Metoprolol is selective for the heart's receptors, which is why it is generally considered safer for lung patients than older beta blockers. But selective does not mean exclusive. In seniors with significant asthma or chronic obstructive pulmonary disease, even a selective beta blocker, like metoprolol, can tighten the airways enough to make breathing noticeably worse, sometimes severely. Amlodipine has no effect on the airways whatsoever. For a senior, managing both high blood pressure and a lung condition, the safety question has a clear lean, and it leans away from the drug that touches the same receptors their lungs depend on. Nora was 68, a lifelong asthmatic who had managed her condition well for decades. She was started on metoprolol after a blood pressure reading that concerned her new cardiologist. Within 2 weeks, she was using her rescue inhaler twice as often and waking at night with a tightness in her chest she had not felt in years. Nobody had connected the new prescription to the change in her breathing until she came to me. The metoprolol was the connection, and switching her resolved the breathing within days. The second scenario, where the answer flips, diabetes and the hypoglycemia warning system. When blood sugar drops too low, your body sends distress signals. Your heart races. You sweat. Your hands shake. These are your warning signs, the internal alarm telling you to eat something before the situation becomes dangerous. Metoprolol blunts those alarms. The beta receptors responsible for the racing heart that warns a diabetic senior their sugar is dropping are partially blocked by the drug. The sweat response may still come through, but the most noticeable signal, the hammering heart gets quieted. A senior on metoprolol and insulin or certain oral diabetes medications can drift into dangerously low blood sugar without the warning system that would normally stop them from getting there. Raymond was 74, a well-controlled diabetic who had been managing his condition carefully for years before metoprolol was added for his blood pressure. 3 months later, his wife called for help because he was sitting at the kitchen table, unable to answer her questions. His blood sugar had dropped to a dangerous level. He had felt nothing beforehand. No racing heart, no obvious warning. The alarm had been running the whole time. The metoprolol had simply made it too quiet to hear. Tell me in the comments if you or someone you know is currently on both a beta blocker and a diabetes medication, because that combination deserves a specific conversation with your prescribing doctor that most people never have. I make these videos because those conversations almost never happen in the time available in a standard appointment, and they matter in ways that show up in my department when they are missed. If you have not subscribed yet, this is the channel that has that conversation with you in advance every single week. The third scenario, the senior on both at the same time. This is more common than most people realize, and it deserves its own conversation. Some seniors are prescribed amlodipine for their vessel wall tension and metoprolol for their heart rate or rhythm, both running simultaneously. Used together, they lower blood pressure through two separate systems at once, which can be a genuinely appropriate clinical strategy. But it also doubles the points of potential failure. Amlodipine's ankle swelling can be mistaken for heart failure fluid retention, which may prompt a dose change in the wrong drug. Metoprolol's fatigue can be mistaken for the sedative effect of amlodipine, leading to the same wrong conclusion. And a senior who is also taking a diuretic on top of both faces a triple interaction where blood pressure can drop far enough on standing to cause a fall. Not gradually, not with warning, but on the way up from the kitchen chair. Evelyn was 73 on both medications plus a water pill for mild ankle swelling. She stood up after dinner one evening and was unconscious before she reached the kitchen doorway. No chest pain, no warning, just the floor. Her blood pressure when she arrived in my department was low enough that the number itself told me the story before the family finished explaining what had happened. Each of her 3 medications was appropriate on its own. Nobody had sat down with Evelyn and walked through what all 3 of them were doing in the same body at the same time. The fourth scenario, what happens when you stop? Bernard was 71 and had been on metoprolol for almost 3 years when his cardiologist retired and his new doctor switched him to amlodipine. Same condition, different preference, seemed straightforward. Nobody told Bernard how to stop the metoprolol. 3 days after his last tablet, he had to call his son from a gas station, 2 miles from his house, because his heart was hammering so hard he could not hold the steering wheel steady. By the time his son got him to my department, his blood pressure was higher than it had been at any point in the 3 years he had been medicated. The new drug had not failed. The old one had not been stopped correctly, and nobody had told Bernard there was a difference. This is the conversation he never had, and it is the one I want you to carry with you, regardless of which of these 2 medications you are on. Amlodipine can be stopped relatively gradually, without a significant rebound effect. Metoprolol cannot. Your heart has been adapting to a reduced adrenaline signal for however long you've been taking it, and the receptors it acts on become more sensitive over time as compensation. Stop the drug suddenly, and that adrenaline signal hits receptors that have been primed to overrespond. Blood pressure spikes. Heart rate climbs. In someone with underlying coronary artery disease, that rebound can trigger a heart attack or a dangerous arrhythmia. The drug that was protecting the heart becomes, in its sudden absence, the reason the heart is now under its greatest strain in years. If you are on metoprolol and your doctor wants to stop it, whether to switch to amlodipine or for any other reason, the word you are listening for is taper. A gradual reduction over days to weeks, not a last tablet today and a new one tomorrow. If your doctor does not mention a taper when discussing stopping metoprolol, that is the moment to ask for one. So here's the honest answer to the title's question. Amlodipine is generally the safer choice for seniors with significant lung disease, seniors who need a drug with no effect on heart rate or the adrenaline system, and seniors for whom stopping or adjusting medication may happen unpredictably. Metoprolol is often the more appropriate choice for seniors with certain types of heart failure, seniors with a fast or irregular heart rate that needs direct rate control, and seniors whose blood pressure is being driven more by heart workload than by vessel wall tension. The same senior on both for different reasons, which is more common than most people realize, deserves a doctor who has thought about how those two systems interact when both pedals are being managed at once. Neither drug is universally safer. The safer drug is the one prescribed for the right reason, in the right body, managed correctly for as long as it is taken, and stopped the right way when the time comes to stop it. Bernard is doing well now. His metoprolol was restarted at a low dose and tapered off properly over 2 weeks before the amlodipine took over completely. His blood pressure is controlled. He drives himself everywhere he needs to go. The information that would have prevented his crisis was simple, available, and never passed to him. If this is the first time you are hearing about the rebound effect of stopping a beta blocker, you are not alone. And that is precisely the kind of thing this channel was built to make sure you hear before you need it rather than after. Subscribe. And the next time a doctor tells you to stop one of these medications, you will already know the question to ask. Not, how do I start the new one? How do I safely stop the old one? I'm Dr. Miles. Thanks for watching, and I will see you in the next video.